In this video, Garet Hil, a living kidney donor and the founder and CEO of the National Kidney Registry, and Dr. Robert Montgomery, chair of the Department of Surgery and director of New York University's Langone's Transplant Institute, participate in an open discussion in regards to eplet matching technology and its importance with respect to donation.
This really started with your personal experience with your heart transplant. So if you could tell us a little bit about how you got involved in this and what it meant to you.
Sure. Well, first of all, thanks, Garet, for for inviting me to discuss this. And this is, this really started with a kind of a really personal story, which is that I had a heart transplant in 2018, and when I was trying to get back into the operating room, that was inhibited by the fact that I had had many side effects, but the one that is relevant was a tremor from the tacrolimus, which is, one of the main immunosuppressive drugs that we have to take in order to prevent rejection, also called Prograf.
Bob, on a personal level, you were one of the first patients, if not the first patient, to actually do this. Look at the eplet match. Again, it was a retrospective look. You couldn't impact it, but you used that to better manage your immunosuppression, lowering it. This was before the research. There was only, I think at the time, maybe one research paper out on this. We've got 5 now. What gave you the confidence, way back then, to move forward on this? Because it was, there wasn't a whole lot of research out yet.
Well, I guess, when anyone does these sort of risk benefit, measures, there's a lot that's involved. In my case, it potentially threatened my job and my career. And so the stakes were pretty high. It wasn't just a nuisance. It was a real problem for me in getting back into the operating room and doing what I love, what I've spent my whole life building. So, I was impressed with the initial data. You're right. It wasn't a large series. It was retrospective, but it was built on, really good science. First of all, our understanding of eplets and the importance of eplets and the immune recognition of the eplet. And I had enough confidence in that sort of equipoise of risk benefit that it seemed like a good decision for me. We have, several more papers from the Winnipeg group, and then we also have studies from several other groups in the US and Europe that all support the original Winnipeg conclusions, which are that patients who receive a transplant with a low eplet mismatch load are less likely to develop rejection, are less likely to develop hazardous antibodies against their organ, and are more likely to have a longer period of function of their organ. So everything now is sort of, from these studies is pointing towards the power of the eplet match.
So Bob, you're the lead investigator in a prospective clinical trial. I know it hasn't been accepted yet. It's in the proposal stage. Give us kind of a quick overview of that clinical trial.
Right. So here's the way the clinical trial that we've envisioned would go. So we take the patients who are compatible with each other by blood type and by tissue. They're compatible, but they're unlikely to be the best match for each other. Okay, so just based on probability alone, the likelihood of getting one of these low eplet mismatches from just bringing, a relative or a friend to the table who is going to donate directly to you is only about 15%. So 85% of the people who receive a kidney, a living donor kidney, from their loved one, the person who donates to them directly, miss out on this opportunity. So first of all, it's an opportunity to get a kidney that is predicted to last longer, have a lower risk of rejection, and a lower likelihood of retransplantation in the future. That's the big bonus. But then beyond that, what we have proposed is that we engineer a large number of these transplants in patients who are compatible by putting them into the NKR, and in a purposeful way, matching them into one of these low eplet mismatch transplants. So you uncouple that donor and recipient, you put them into the pool, and then you find the best donor for them. And their donor gives to someone else who they're better for. And then we randomize those individuals into 3 different immunosuppressive regimens. The traditional ones that just, involve the tacrolimus and CellCept, one where we have a reduced dose of the tacrolimus, so they're less likely to have the side effects and less likely to have actual kidney damage from the drug. And then a tacrolimus-free arm, which we use another drug that doesn't have those kinds of side effects. And then we compare the 3 and see if, compared to standard of care therapy, whether these low eplet mismatch load patients do just as well with lower immunosuppression as they do with standard immunosuppression. And then you've realized a big benefit.
What are the kind of main side effects that we're trying to minimize with lower immunosuppression? What are the key things?
So the main side effects that patients who are on standard immunosuppression will get are an increased risk of infections, an increased risk of certain types of cancer. These are sort of the long-term side effects and risks. Potentially a worsening of their high blood pressure, their hypertension, potentially a worsening or a development of new diabetes. Some patients will have weight gain, and some patients will have a worsening of cardiovascular disease. And then sort of all of these, what I guess many people would consider to be more minor side effects, like tremor, like this feeling of being on edge all the time, problems with sleeping. Those are kind of the side effects that really can affect quality of life. And patients who are taking immunosuppressive drugs, when they take quality of life tests, do complain more about their quality of life not being what it could be. And so all of these things, are are really important in the short term and especially in the long term. And in addition to that, tacrolimus can actually affect the longevity of the kidney because it causes less blood flow through the kidney, which can lead to, long-term damage, scarring of the kidney, and that sort of thing.
Bob, talk to us about the importance of this with pediatric patients, young folks.
So, I take care of a lot of kids who end up getting sensitized and come to me because that's been an area of focus of my career. And they're usually on their second or third kidney and they're in their early 20s. And they're in a real bind because they've gotten their first kidney, which maybe failed, during the adolescent years. And maybe, they had trouble maintaining their levels of their immunosuppression, and had these dips in their levels, and as a result developed these hazardous antibodies against their donor that then cross-react with other donors, and then maybe received a second transplant that was in a less than ideal situation because their immune system was ready to respond to that organ, had been primed to respond to that organ, and then lost that kidney in a fairly short period of time. And now they're coming around for their third transplant in their early 20s. That's a huge problem. That means that they're going to spend a lot of their life on dialysis, waiting for these long shot matches because they're sensitized. Unfortunately, they're going to have a rough time. So if we can start out with that first transplant when they're children, and get them in a situation where they receive, one of these really favorable matches from a living donor, that's going to give them the longest run, from that kidney. And maybe then we can put them into a trial where we can reduce their immunosuppression, reduce the side effects, which in the teenage years, these side effects from these drugs can really affect their ability to socialize effectively, and oftentimes the adolescent response to that is, I just don't want to take these medications, and then they get into the cycle. But if we can get them on lower doses with less side effects, I think we're in a much better position for them to, take their medications and have that organ, survive and work for decades and decades. So maybe they only need one kidney for the rest of their life.
You and your team at NYU have actually been doing this for probably about 6 months now. What's your experience as far as wait times? So you go, you have a compatible donor, you can be transplanted in the next month, but you want to get a better match. There's certainly a trade-off there. You may have to wait a little longer. What's your experience been at NYU on the wait times to get that low eplet mismatch donor?
Yeah, so it's really interesting because, if you tell somebody you're incompatible, with your donor, it's not, it's very straightforward. In most cases, they see the wisdom of paired exchange right away. But if they're compatible with their donor, they frequently have some bond with that donor, and they don't even think twice. They just want to move ahead and get their transplant with that donor. But if you introduce this idea that, look, you're in a situation where, that donor is probably not the best donor for you, and we could find you a low eplet mismatch donor through kidney pair donation, and that has the likelihood of that kidney lasting longer, lower risk of rejection, and maybe the possibility of reducing your immunosuppression. Most people see the wisdom of that right away. And we, did with your group, did some simulations and showed that we could find these donors pretty quickly. It didn't really add that much time to, their wait than you would normally incur just scheduling a transplant and getting everybody ready for the transplant. It generally could be done within about 3 months through NKR, getting the ideal donor. It makes sense to people when you explain it to them. And it's pretty rare for patients to say, okay, well, I'd rather still stay with my donor. Most patients want to uncouple, go into NKR, at least that I've spoken to, and get this better match.
3 to 5 years from now, we're going to have a much better understanding of what a good match is. And it will change everything we've done in the past because it'll erase a lot of stuff we thought was important. Where do you see this 10 years from now? So step out of your body and look past, go 10 years out. What does this look like in 10 years?
All right. Well, so you've given me the freedom to have sort of a blue sky conversation. So this is where I see this going. I think that that almost all live donor kidney transplants are going to be done with the intention of matching people to a low eplet mismatch load. I think that those patients who, the majority of patients who receive this more favorable match will be on lower levels of immunosuppression. And then I think that the field will see the success of this, and we will change the allocation system for deceased donors to emulate this, and deceased donor matching will have a high, a very significant component of eplet matching in the algorithm. So that's when I look into the future, and obviously, we've got to prove all this and do the studies, but that's what I see.
This is the fun question. So about 20 years ago, you and your team innovated, in my opinion, the greatest innovation in paired exchange, which was the Domino Chain. And the Domino Chain starts with a Good Samaritan donor and then, sets up a series of dominoes. That innovation increased the power of paired exchange by at least 10x because you didn't have to get back from the pair you were giving to. That innovation is the foundation of what we're doing today. Just how do you feel about that? Because this has come full circle now, because this innovation couldn't have happened without that. And that was like 20 years ago, right?
That was 20 years ago. Yeah, I mean, it's extraordinary. I don't think we had any idea where this was going to lead. I mean, I think we were looking through a keyhole. We knew it was important, but I don't think we knew that it was going to lead to almost 1,000 additional transplants a year in the United States. And so, the full circle part of it, I've in my journey during that 20 years, I've come really close to dying several times with my genetic heart problem. And for whatever reason, I'm still here against all odds, really. And it feels to me like there's that's not a random thing, that I'm here for a reason, and part of it is to see this thing through as it goes full circle. I just need to, continue to work with you and others, on making that a reality, because I think it's going to have a gigantic impact on our patients' lives. And the single biggest problem that we have in kidney transplantation now is that the organs have a half-life. So, for a deceased donor organ, 50% of them are lost between 8 and 10 years after the transplant. And, if you think about that, if you're in your 20s, 30s, 40s, that means you're going to have 3, or 4 transplants during your life. For living donors, it's about twice that. It's about 18 to 20 years. But look, if we're onto something here that can change that math, it's going to be one of the most important things that any of us can do in our lives. So I'm super excited about this, and we're going to make this thing happen. You and I and all the others who are working with us so hard on this. So I couldn't be more thrilled to be here and to be involved in this.